Good afternoon, everyone, and welcome. We'll give it just a few more seconds as everyone joins us today. All right, we'll just give it a couple more seconds before we get started. All right, let's go. Well, hello, everyone, and welcome to the Industry Showcase session today on September 20th. My name is Ashley Caesar. I am the Programs and Events Specialist here at Digital Health Canada. So today's Industry Showcase session is called Back to the Bedside. And it is a pleasure to introduce you to Dr. Glen Geiger. He is a Chief Medical Information Officer, practicing internal medicine physician, and the physician lead for the Ottawa Hospital. All right, we'll have time for Q&A at the end of today's presentation, so please feel free to type your questions in the chat box at any point. All right, thank you all again for being here today. A warm welcome to all the attendees. And I'll now pass the screen over to you, Dr. Glen. Oh, you're on mute there.
Hang on, I'll just get our slides set up here and let me see if I can share those properly. Here we go. Okay, is that working?
Yes.
All right. So thank you again for joining us today. I just was asked to present on our bedside strategy that we've been working on for a number of years. So I'm going to go back and go over the history of it. I'll explain our site as how we organize ourselves. I'm going to discuss our strategy with regard to mobility. Then I'll explain how we got into the Back to the Bedside strategy, and then show what it has done to the workflow of our staff. And then we'll go on to discussing our more recent investments in bedside technology in the recent past and where we're heading. So who we are. So I'm going to start by discussing this from the viewpoint of the Ottawa Hospital. This is our picture of the region we serve, the Champlain-Lynn, and the picture on the other side shows several of our campuses. Oops, don't mind me. We have a $1.2 billion operating budget, over 1,000 hospital beds, although it varies depending on where we are in the pandemic. You can see the statistics there for our employees, our physician community. We're an academic health science center, so we have residents and students. We have a large number of admissions and surgical cases per year. Once again, all this has been turned a little bit upside down by the COVID pandemic, so I don't know quite where we are anymore, but this is the statistics we used to use before the pandemic began. We are on the 3 campuses shown in the pictures there, as well as have the Ottawa Heart Institute. We're a regional partner with satellite dialysis sites and satellite chemotherapy sites, and $60 million in research grants. We're also in the process of building a new campus, but that's still a number of years off, so I won't show pictures of those plans. So I said that we're a mobility pioneer, and the Ottawa Hospital has initiated a mobility strategy back in 2010. And this was predicated around the idea that we wanted to make sure our physician community was engaged in our electronic medical record efforts. And that's the genesis of this idea. So this slide shows a rough timeline of when we started. So the left-hand side, there's the tail end of 2010. We began work on a mobile viewer of our electronic medical record technology to be accessible from iPads. We piloted in November of 2010, and the pilot was so successful that we went out and began purchasing and sharing iPads with our physician community and rolling them out in the latter part of 2011. We developed the ability to do electronic ordering on a mobile platform in the latter part of 2011 and turned that on in 2012 with electronic ordering through an iPad device. And then ultimately we were able to deliver electronic medication reconciliation both on our desktop platform as well as on our mobile platform in 2013. So what was the impact? We deployed over 3,000 iPads to clinicians in that time period. The physicians were using our custom electronic medical record through these devices, and we had lots of anecdotal feedback about how powerful the mobility paradigm is for being able to do your work with a device you carry with you instead of having to go to a workstation in a care environment in the nursing station or somewhere else. And as I said, we were the first hospital to do electronic ordering in 2012. So this was our first introduction to sort of freeing physicians or clinicians from the sitting at the desk type of model that had existed before, sitting at the desk with our old legacy computer systems or sitting at the desk with the patient's paper chart. So that was so successful that I thought it'd be a good idea to go one step further. So herein comes our cautionary tale. We, at that time, as I said, we were building our electronic medical record. We were connecting everything. Our team was very good at connecting technology together. And so I had the bright idea that nursing staff could enter patient vital signs into computer workstations, and then they would link automatically to the view of those vital signs on the mobile device that I was carrying. And I thought this was a very clever plan. The nurse involved looked at me like I was demented, and she asked a very acute question. She said, "Why do you think I should copy vital signs from one computer to another?" She basically pointed at the devices we used for collecting vital signs and pointed at the nursing station and suggested that she was going to be the one who was porting the information from one electronic device to another electronic device just to satisfy my convenience. So as a guy who's sort of an expert in technology, I was rather embarrassed to think that it hadn't occurred to me what a perhaps ineffective solution that would be. So my desire to see information nevertheless would have had a significant impact on the workflow of our nursing staff and other colleagues. So this is where the back to the bedside strategy truly came from. The recognition that our mobile device strategy, where physicians and others were carrying iPads so they could access information, wasn't enough to ensure smooth workflows in inpatient clinical settings. So we referred to this as the last 30 meters problem, wherein we recognize the difference between the nursing station and the distance to the patient's bedside, and the fact that nurses and other members of the team are moving back and forth between these environments on a regular basis. They go to the patient's bedside, they go back to the nursing station to do documentation. They go to the patient's bedside, then they go back to the nursing station to find devices such as our oximeters, our sphygmomanometers, and other types of equipment. And so there's constant flow of shuttling back and forth between these different settings, which is where the 30 meters problem comes in. So we decided to look at this problem analytically and examined it from a number of different angles. So we reviewed the inventory of electronic vital signs equipment that we had. We looked at the number of different devices we had, and we paid particular attention to nursing time, and I'll show you that in a second. And this ultimately resulted in building out a list of benefits and a business case for the back to the bedside strategy. So first we looked at our inventory, and I make note of the fact that we had a lot of different vital signs equipment. And you can see in that pie chart all the different models of equipment we had at that time. A lot of this equipment was already due for replacement, and some of it was going to need to be replaced in the next few years. The nursing staff and others in the inpatient areas were constantly complaining they didn't have enough of this machinery and that it was hard to find. We had a biomed team that had to find these devices and calibrate them, and they had evidence showing they were not keeping up with servicing the volume of equipment that we had, even though our nurses felt that it wasn't enough. These devices were unable to connect to our networks, and some of the devices had a different array of probes on them to do different things. So the nurse could experience a situation where they went to get one of the devices and found that it didn't have all the things that they were expecting to find on that particular device, and that could be frustrating. We also had other devices besides the basic vital signs equipment. We also had a bunch of pulse oximeters. We had a whole bunch of thermometers, once again, also sitting in nursing stations, having to be retrieved whenever we're going to care for the patient, and having to be calibrated and maintained by the biomed team. We had a variety of manual sphygmomanometers, including the mercury ones that were still sitting around the unit and which had been condemned by Environment Canada as unsafe for the workplace, and they were still in our work environment. So that was what our review of our inventory showed. Moving on, we did a time motion study of the 30-meter problem, wherein we had a team go and observe how much time the staff spent looking for equipment when they went to do the patients, testing patients, oximeters, and vital signs equipment. How long do they take searching for things? And you can see we have one outlier unit that didn't have enough devices, and so the nursing staff spent a great deal of time looking for them. But on average, per vital sign collection, most of the units saw time delays of 1 to 2 minutes per vital sign collection, with a sort of tight variation on most units, with the exception of that one. So this is what our time motion data showed. And we didn't survey the whole organization, but we did a reasonable sample of the organization to get a sense of what the data really looked like. We made a video, and I'm going to see if I can get this video to play here, and see if the sound will come through. So hang on, bear with me. It's about 1.5 minutes. So follow with the video and the measurements we've taken, we began to try to quantify the benefits of the bedside strategy. So we estimated the amount of time the nursing staff would need to spend using the mobile, like the stand-based mobile equipment, the thermometer probes in the nursing station, the oximeter devices sitting in the nursing station, and so on, and felt that we could attribute a time cost of 2.5 minutes per event. The time to clean the devices between moving them from one patient to another was an additional 37 seconds. So the non-evaluated time was estimated to be about 3 minutes. And this meant that in an inpatient area in our hospital, which I gave you the specifications at the beginning, we estimated that we were wasting 252,000 hours of nursing time, valued at $11.3 million. Now, this is not a real dollar savings in terms of the operating budget, but is a soft saving in terms of the time being wasted. So this led to a business case, which I'm showing here. So we created a budget for replacing the devices and putting devices at the bedside. Then we were able to subtract the cost of replacing our existing fleet of devices anyway, the additional spending we'd need for more devices to fill in gaps, and then added in the replacement of the oximeters, which at that time were separate devices, and thermometers as well. So this created a 3-year cost or net cost of $4.3 million, set against the soft savings of $11.3 million repeating annually in terms of nursing time. And this was the base of the business case. Or that video that I showed was shown to the senior financial team, and the business case was presented to the financial team as well. We also listed out a bunch of important but difficult to quantify benefits, including the infection control issues, the quality of care issues associated with transcription, the accuracy of the devices by ensuring the fixed fleet was being calibrated, and the improvement in care when vital signs were captured immediately rather than waiting for transcription onto a piece of paper or even a computer system later in the day. So this slide was presented to our senior leadership team, suggesting we would achieve the time savings. We would improve the goal of having less equipment, cluttering the nursing station, other parts of the ward that wasn't being looked after properly. We would improve our ability to clean the devices by having a dedicated device per patient during their stay, and then clean the device between patients rather than between measurements. And we would capture the vitals immediately from the devices and no longer rely on transcription of the data onto paper or into the computer, which had been my original suggestion, which one of my nursing colleagues had poo-pooed at the time. So that was the case we made to senior leadership, and the rest, as they say, is history. So they accepted this argument, and we purchased these devices, one for every bedside, and delivered the workflow of direct communication between these devices and our electronic medical record. Even with this project, we piloted it initially, and this is some of the feedback we got in the initial pilot. We got positive survey data on, as you can see, on recommending the solution, the fact that it meets the expectations, it's easy to manage and clean. It's a net positive, and it's intuitive and easy to use. So all the scores that you can see here are in the strongly agree or agree category. And no negative comments were obtained for the initial pilot unit. Verbal responses, easy to use. I don't like to take a scrap of paper in the room to document the vitals. Staff are happy with the monitors, and no negative comments were received. I did have one physician who pined for the mercury-based sphygmomanometers, but I haven't heard that comment in recent years. So with that, we piloted, and then we rolled out these devices across the organization where they remain in use today. So that takes us up to a number of years ago. The next thing that happened was Project Fusion, which was our large-scale electronic medical record implementation. Prior to that, we had a locally developed solution which provided some functionality, but was not a comprehensive electronic medical record. Project Fusion was undertaken to address that. So basically, 6 organizations got together to implement a comprehensive shared electronic medical record. And you can see the 6 organizations listed over there in the top upper right-hand corner. We went live on June 1st, 2019. And we've also brought in the Group Health Center from Sault Ste. Marie has joined our Atlas Alliance, which is the name for this sharing. And then on November 5th of this year, we're going live with 3 more hospitals in our region. And we will now then be doing data exchange with 21 of our long-term care homes in the region as well. So this is the way the initiative was set up, and it's now expanding to include other partners in our region. As part of this, it gave us an opportunity to extend the back to the bedside strategy through the use of or reliance on workstations on wheels and handheld devices, which we supplied for all the nursing staff when on shift. So they could use either the larger workstation, the mobile workstation, or the handheld device, or the desktops in the nursing station. It's always the clinician's choice as to what they wish to use. But we offered all of these options for our staff in order to encourage and develop more bedside-based workflows, scanning of patients' barcodes, scanning of medications at bedside, and so on and so on. In addition, we integrated our dialysis equipment so that all that documentation flows directly into our record, right from the bedside in the dialysis suite. Our portering team used mobile devices to know when to help transport patients from one part of the hospital to another. Our glucometers no longer require synchronization through docking stations, but are actually Wi-Fi enabled. Our ECG carts are Wi-Fi enabled, and our point of care equipment in ICU and in the emergency department setting also communicate directly to our electronic medical record now. So these are all an extension of this back to the bedside strategy I was referring to earlier. And now they're applied across our entire Fusion project or the Atlas Alliance. What were the benefits of this? Well, in addition to the electronic medical records require staff to spend more time sitting at workstations documenting stuff. So giving clinicians some tasks which are automated is an important offset to the transition to electronic medical records. You're requiring them to do things they didn't do on a computer before. It's very important, if we can, to make some of their work easier by eliminating steps by the automatic transmission of data from what are essentially computers to our primary electronic medical record without them having to do manual transcription of this data themselves. So anything you can do to streamline the workflows that are possible offsets the work and the challenge of transitioning to an electronic medical record. So all the stuff you're seeing on the screen was a huge advantage to our implementation. And then we leveraged the bedside devices we already had. But here's an example of what else happened. So during the pandemic, we were able to use all our bedside vital signs devices to directly connect them into a centralized oxygen saturation monitoring system inside the nursing station. So as many of you will be aware, the challenge of putting on a PPE to enter the patient's room certainly made some care activities more difficult. Having bedside equipment already connected to allow the nursing staff to complete their work in the room and have the system automatically updating the electronic medical record without them having to leave the room. So that was an advantage. But in addition, our ability to monitor patients when we weren't in the room and focus on oxygen saturations using the bedside device connected to the patient and relay that information to a monitoring station was also an advantage in keeping track of these patients. As many of you would know, how sometimes they deteriorate quite rapidly, and having a secondary monitoring station inside the nursing station was a huge win for us. So this was just a pickup because we'd already established this inventory of bedside devices, and we're able to leverage that investment during the pandemic. So where are we going from here? There's lots of things we have in mind, but I'll just discuss a couple. So IV pump integration. So we currently have a fleet of smart IV pumps, and we are able to update their drug information libraries using Wi-Fi because they're connected to the Wi-Fi network. So we recently changed the way we administer insulin. Back at the beginning of July, we reprogrammed all the smart pumps in the organization to address new workflows related to insulin infusions. But things that we could do with them is these pumps are smart enough and they're connected to the Wi-Fi, they're actually able to upload what they've done. They've been able to upload the volume of medication infused into the patient in the past hour. And therefore, the pumps themselves could do documentation. Just like transmitting the vital signs from the bedside, we can transmit the infusion volumes directly from the bedside to the electronic medical record, and save the nursing staff that step of documentation from, once again, what is a computer into another computer. You can take this idea a step further, and the actual electronic order for the IV infusion can be downloaded into these pumps, thereby programming them with the correct drug and the correct rate of administration for the medication, loading it immediately into the pump and having the nurse check it as opposed to the other way around. So this is a safety initiative where the orders would be directly connected to the pump and it would be programmed appropriately based on the original order with no need of manual re-entry of the drug order into the pump itself. And then these pumps are also capable of uploading or transmitting the alarms into the nurse's mobile device and into the electronic medical record and into a central monitoring station. So when the infusion is completed, when the bag is empty, these markers or transmissions can be sent into the network through the Wi-Fi and can be used for improved workflows related to refilling the pump, documenting the completion of the infusion, and so on. So these are all examples of bedside strategies which we're going to leverage with regard to these smart IV pumps. What else can you do? Hospital and home strategy. So this may seem like a strange segue from the inpatient world, but basically there's nothing to stop us from viewing the patient's home as another bedside environment. So many of the devices that patients have available to them in their home, glucometers, blood pressure cuffs, and so on, can also be enabled through Wi-Fi and connect to their own personal MyChart. Ventolin puffers and other types of inhalers can be Wi-Fi enabled to transmit whenever the inhaler has been used. Infusion devices in the home can be connected to MyChart, and point of care testing devices can be connected to the patient's own chart. That sort of technology means the patient's record can be updated whether at home or in the hospital or on dialysis or in our chemotherapy suite or wherever, and information becomes one seamless whole, and the home environment for some patients can be an extension of the inpatient or clinic-based environment. This type of workflow also supports more robust virtual visiting, where in a virtual visiting session, the clinician visiting the patient virtually can also see real-time data the patient is supplied from their own home. And you already has that, instead of asking the patient, well, what was your blood sugar reading? What was your blood pressure reading? And so on. It would all become immediately available to a virtual clinician overseeing the patient's care in the community. Furthermore, if you take this one more step, the collection of vital signs device, both in the hospital, in clinics, as well as in the patient's home, allows you to use artificial intelligence or predictive analytic tools to monitor patients' care, monitor the clinical condition, and detect when whatever parameter in the glucometer, the inhaler, the patient's weight, the patient's blood pressure, or what have you, has drifted out of a safe range and requires active intervention. So the availability of bedside technology in the patient's home environment will ultimately support more diligent monitoring by algorithms and predictive analytic tools to make sure that patients remain safe when they're receiving complex care in their own home. And then all this leads us to a greater ability to manage population health. Lastly, I'll just mention the notion that where we've been heading with all this mobile device, bedside technology, and the integration of all these tools is ultimately to a larger vision of team-based care, where our clinical teams are connected in tighter and tighter circles, all providing collaborative care for the patient themselves at the center of this diagram. So today, not only do we have bedside devices, but we also enable secure chat messaging between clinicians, and all of this adds to the integration of information to our technology and our electronic medical record systems in order to make sure that the whole team is involved in providing the best possible care and the most timely care for the patient that we can. And this is a function of both the inpatient and ultimately the outpatient environment. We'll see the same kind of vision of team-based care and elimination of asynchronous communication such as paging. So that's kind of where we see all this going. We've made a significant progress on this journey, but as you can kind of see, we're not actually finished yet. I think there's going to be more integration of technology, both at the inpatient bedside, and we have yet to really fully embark on an adventure to integrate the patient's home technology into this type of environment. So those things lie ahead of us still. And I know that was a bit of a whirlwind tour, but I'll stop there, and there should be lots of time for questions.
That's great. Thank you very much. What a great presentation. Very interesting video, actually, by the way. Let's jump into our questions here. So first one is, in your next round of replacing the older VSMs, are you looking at wireless?
The devices we have are wireless. At the time we installed them, our inpatient Wi-Fi network had too many dead zones, so most of them were actually wired in. But moving forward, we've upgraded our inpatient Wi-Fi. We don't have complaints about dead spots anymore, so I'm sure all this stuff is going to be wireless. Yes.
That's great. Okay, next, can you please share what brand devices were purchased, used for the vital signs? For example, what vendor was selected?
Those devices you saw in the later pictures are the Welsh Allen Spot Vitals equipment. Once again, we bought the devices that had the blood pressure, heart rate, oximeter, temperature probe attached to them, and then the nursing staff were able to enter the patient's respiratory rate on the screen, and they were able to enter pain scores on the screen as the fifth vital sign. And so they were able to capture all those things through the same device. And we eliminated all the separate oximeters and temperature probes. They were all taken away with when we transitioned to the one device, as my business case suggested.
Okay, so this is a two-part question. And how did you integrate the dialysis machines?
That was an important piece of work. We basically worked with the dialysis machine vendor and bought middleware, which allowed us to directly upload the dialysis machines through a third-party interface tool into our electronic medical record. Prior to that, our dialysis units were recording all their information separately. They had their own computer system, but when you couldn't see it from anywhere else. Only the dialysis team could see the information of how the dialysis run occurred. Today, when the patient goes down for dialysis, they can be off the floor. I can actually see their vital signs on dialysis from somewhere else. Like I don't have to be down there in the unit. You can actually see their vital signs during the dialysis run. You can see their blood's been transfused. You can see what their blood pressure was during dialysis and all these things. So it's fully integrated, but we did have to use third-party integration technology to connect it to our electronic medical record. It's a great advantage to this type of workflow and an extension of this idea.
Okay, great. So like, I believe that answered that next question. What technology did you use?
Yeah. And, if you go to the dialysis vendors, you'll find that, they have their own proprietary stuff, but basically these machines, as with most medical equipment, have the ability to transmit information into a network. You just have to format it properly to make sure it can be received. But most devices have this capability today.
Great. All right. Here's our next questions. Are those bedside devices that check vitals continuously monitoring patients hooked up to the patient? Or does the nurse go to check vitals still? Therefore, the benefit being it updates immediately in the EMR?
Yeah, so we want the nurses to go to the bedside. So the devices were originally purchased for what we call spot vitals. So let's say 3 or 4 times a day, the staff go in to that patient's bedside to collect vitals. What you saw in the example with COVID-19 was that we were able to transition to the continuous. We basically said, well, we wish to monitor these patients continuously. The device is there, and we were able to, as long as the patient's willing to wear the oximeter probe, for example, we were able to collect continuous oximeter readings from the patient's bedside with the same device. So that was they were not intended for that purpose when we built the business case, but it was a significant win during the pandemic to be able to transition these devices to continuous monitoring when appropriate.
Great. Here's a nice, interesting question here. Is there a patient communication means within the system?
So do you mean, do the patients communicate through these devices? No, they don't do that. Moving forward, and I guess I should have had a slide about this, how we communicate with patients, so they're part, inpatients particularly, so they are part of the care team, is a good example of somewhere else we're going to go, right? With more direct links to the patient at the bedside, so they can ask for the nurse to come, they can ask for water, blankets, or things like that through more enhanced communication with the patients at the bedside, but the vital signs devices don't do that. At least the ones we have don't do it.
All right, great. Were there privacy concerns with the nurses and physicians using iPads? How do you track lost iPads or lock it down to protect patient data?
So we had to be very careful about how we did everything with our iPads and other technologies. So originally back in 2010, when we initiated the iPad strategy, we had mobile device management software on all devices. We ensured that our software was always built to never retain patient information on the device should it be lost, and we retained the ability to wipe the device if it was stolen. So if anybody lost the device, we have the ability for remote erasing of the device if needed. With more modern technology since 2010, security in mobile devices gotten better and better. all vendors who sell software, medical software for mobile devices, ensure that privacy issues are addressed and patient data never remains on the device. So, but initially we had to spend a lot of time making sure they would work properly. Today, most solutions have that type of functionality and that privacy requirements are already built in. But when we started, it was all brand new.
That's great. All right. Have you considered adding patient-reported data, such as pain scores or well-being data, into the data captured into the EHR?
So our vendor has a inpatient bedside functionality where some sites, not us, have loaned the patient at the bedside their own device or allowed them to install an application that allows them to interact with the care team from their bedside. And so the answer is our vendor has that functionality. We have not deployed that functionality, but that's another good example of where to go with this idea, right? Is make the patient, in this case, an inpatient, a member of the care team. So our inpatients can see their data, but we don't have specific functionality for them to interact with a mobile device and link that to the inpatient care team directly. So that we haven't done, but it is available and it's a great idea.
All right, here's an expansion to the question. The previous question: is there a patient communication means within the system? So the expansion is: can they ask questions of the team? Similarly, can the patients monitor information flow, such as when the tests are ordered, completed, and results are available?
Our patients do have the ability to view what's going on as an inpatient, and many of the patients do today. We have a huge, I didn't show this in the slide. We have the functionality to do it, and most patients use MyChart today. We have about 380,000 people on MyChart. So many of our inpatients are watching the results as they go, but we don't have the ability for them to enter information.
All right, a few questions here. Are all the VSMs connected to central monitoring at all? So the team, all the team care stations?
We only set up that for the COVID units. We didn't set that up at all the other units as being perhaps excessive, but we would have the capability under special circumstances, yes.
All right, so next question: instead of using VSMs, did you ever consider procuring low equity physiological monitors?
So what type of monitors?
Low equity. If you'd like to expand on that question, feel free to type it in the chat box, but we'll move on to the next question here. The centralized monitoring aspect is interesting, makes me think of an air traffic controller. Are new roles and responsibilities demanded by your implementation?
So as we integrate further, so let's imagine that we went as far as integrating all the pumps. What you could do is you would increase the value of a central monitoring area that was watching all the pumps in a particular region, right? You could have the pharmacy recognizing when the pump is running out of an infusion volume, like the bag is finishing, and actually proactively send the bag up to the unit, or you could develop new team care models because other people can see what's happening. In addition to that, on a slightly larger scale, we're in conversation about remote ICU monitoring. So once again, taking this, it's not the bedsides within our organization, it's our staff could monitor bedsides in other locations using bedside monitoring equipment connected on a continuous or intermittent basis to patients. We can monitor infusions in other areas. So as we're actually talking about virtualizing care delivery and the ability to develop new oversight models when you have all the information available. So you can monitor centrally in the nursing station, or you could have one central location monitoring multiple nursing stations or patients in other geographic locations. All this sort of stuff is in our future, as I'm sure you can imagine.
Right. So for remote patient monitoring, are you looking for cellular capable devices to send the data to your current platform?
Generally speaking, I think most people would rather use Wi-Fi enabled devices, but nothing stops you from using a cellular channel to do that. It's the same concept, but I think for most people, the idea would be they would have a device in their home using Bluetooth or Wi-Fi to connect it to their MyChart in their home computer, which would then upload the information into their permanent electronic medical record through their home system. So that would be the workflow for most people. Apple and Microsoft have a number of different entries in this area as well. So this is a developing area, and you're going to see improved technology. People have used the example of the Apple Watches to monitor patients' vital signs. That would be through cellular, right? If you're wearing a watch and it's monitoring your heart rate, for example, you could send that directly through the cellular to your electronic medical record. And I'm sure that's been done. We have not done that yet.
Great. All right. So next question. Are there any trends in ongoing pain points for clinicians, specifically nursing, in the integration of these technologies? For example, alarm fatigue, interoperability or tech issues, errors, frustrations, wishing we could go back to the old versions.
I think the main issue, I think we don't see many people with these, many of the nursing staff where we do automatic documentation wanting to go back to the old world. In fact, we hear quite the opposite. Implementation of electronic medical record requires staff to use a computer in ways that some people are uncomfortable with. So we always hear feedback about people who feel that the need to document in a computer remains foreign or undesirable. And so we have physicians, we have nursing staff who don't like documenting the computer. We don't have them complaining about integration of vital signs equipment. That's a win. Doing electronic ordering, doing electronic documentation at a workstation is not always a win. And so that's why I think I said it was very important to deliver this solution to offset the negative burden of electronic medical record systems and make it a win, at least some aspects of their introduction, a win for our frontline staff.
Okay, great. We have time for just a few more questions here. What is the scope of bedside device integration you have achieved?
Well, as I said, it's quite broad. So the bedside vital signs devices, the portable glucometers are integrated, the ECG machines are integrated, the telemetry equipment is integrated, the dialysis machinery is integrated. So there's the ventilators are integrated. Like there's a lot of stuff that's connected not just in our sort of inpatient beds, but in other settings. Equipment in our ambulatory care clinics, the same thing. Wi-Fi enabled vital sign machinery in our ambulatory care clinics can be used to upload patients' vitals in ambulatory care. So I spent a lot of time talking about the inpatient environment, but we have delivered some of this functionality in our ambulatory care environment as well, our chemotherapy suites and so on, where, which are ambulatory in nature. The same kind of workflows exist where the vital signs can be collected there. And then moving forward, we'll see this expand to other types of technology as they become available. Like the beds, like the smart beds can be integrated directly. We have not done that, but it can be done, right? And this is another example of the kind of things we talked about. You mentioned, or someone asked about patients entering information in their mobile device while they're in the hospital bed. All that we haven't done yet. These are all examples of new frontiers.
That's great. And how do you realize the benefits from time savings?
Well, that was a good question. I think I was fairly clear that the savings in nursing time are soft savings. They're not, you can't change your staffing model just by doing things like that. If we move forward with the IV pump integration, it's the same thing. You will save time. The nursing staff will save time. It's a quality initiative. The orders will be copied directly into the smart IV pumps. So that's a win, but you don't actually save the operating budget of a large hospital by doing these things. So when we talk about this, I never want to give people the impression that somehow, money is coming out of the system somewhere. That's not the case. These are savings, and having more time for the staff to check on the patient without doing the mechanical task of recopying information to the chart, having the staff more satisfied with their job are important wins, but they're not dollar savings.
That's great. I believe you answered this question, but I will ask it anyway. At your site, are the anesthesia machines in the ORs integrated in your EHR?
I'm sorry, I should have said that. Absolutely, the anesthesia machines are integrated. It was critical that happened. And so I didn't talk about this, but when we delivered our new EMR, what I said at the time was, I want the patient's vital signs to be continuous no matter where in the hospital they are. They come into the ED, they go up to the OR, they go to the ICU, they come to the step-down unit, they go to the floor, they go to the ambulatory care. Wherever they are, the vital signs should be a visible and one continuous record in that entire environment, which is what we achieved. So like I said, when the patient is on the floor, they go down to dialysis. So let's say they're having their vital signs done, 3-4 times a day on the floor. Then they go down to dialysis, and during the dialysis run, they have their vital signs checked every 10 minutes. Well, that is one continuous record of the patient's vital signs. In the same way that lab results from external labs and lab results from internal labs are one continuous record in the system. So part of what we're talking about is the integration into one single record of patient care. I can't tell you how helpful it is to be able to see the information holistically instead of separating into little silos. In the old world, the ICU would have the vitals on one piece of paper, the emerge would have another piece of paper, the inpatient would have another piece of paper, the dialysis would have another piece of paper. You could never see this information. Today, it is all one continuous record, in the same way as lab results, x-rays, or other things are integrated between multiple different sources, giving the clinician working on helping with the patient a comprehensive view of information. And once you start having it, you don't want to go back and let it go. It's really valuable.
All right, so we have one more question. What other integration strategies do you recommend?
Well, I think that there's two parts of integration. One was the vision of what you're trying to integrate, which I just described, and the other is the mechanics, right? So I said that we are integrating with long-term care. So in November, we're going to be able to share information with long-term care, and they will be able to share information with us. We currently integrate lab results from all over the province into our electronic medical record. And so there's the technology required to do that, which can be quite complicated, and you need special teams to make sure they understand the language of the devices that are sharing. Basically, the devices have the way of formatting information. You have to be able to understand the format in order to be able to transmit it. So at a technical level, there's a whole bunch of people you need to understand the technology. But in terms of the vision, the impact is that you're trying to create a continuous record of the patient's care, and that doesn't have to just be vitals, as I said. That could be X-ray reports and other things. So, for example, in the modern world, when I'm looking after a patient in the hospital, if I can see pathology results from Hamilton for that patient, it helps a lot, because the patient would tell me, I used to live in Hamilton, and that's where I used to get my care, and they did a test and they told me what the result was. Well, sometimes the patient's understanding of that result is somewhat unclear. Being able to access information from other locations is enormously helpful. Last week, I was looking after a patient who had started to have high blood pressure in hospital. I was able to look back to the last time the patient was in hospital a year ago, and I could see their blood pressure from a year ago and say, yep, the patient's blood pressure has changed. It's no longer the same as it was a year ago. Well, I was able to do that at a workstation. I didn't have to do anything. I just had to scroll backwards in time and see what the patient's blood pressure was a year ago and could prove that it had literally changed. It was now 40 points higher than it was before. And therefore, we said, well, this is a real change that requires real treatment. It's not like the patients, this is an old problem, it's a new problem. And so we were able to address that way because we had comprehensive information. So technology layers are complicated. You have to have but fundamentally for clinicians, it's do you see and understand the value of having this kind of continuous information collected from all these different points? And then from the staff point of view, can you make your staff's life easier? That video is a really good way of seeing. Many of you may have hospitals or facilities where people are still doing that. And you may not notice it, but when you actually take the video of it, you go, wow, that's a bit scary. And so bearing in mind that it's these frontline staff that have to use these systems, whatever you can do to improve their day is important. Electronic records are tricky to work with. If you can do anything you can do to help your frontline team is a win.
That's great. Well, thank you, Dr. Glen. Very interesting, very informative session today. That is all the questions that we have today. If anyone has any last minute questions, any last minute comments, please feel free to type it in the chat box. All right, so we just have a couple of minutes left. I just wanted to share with all the upcoming events that Digital Health Canada has in the works. We have our first in-person conference coming up this Thursday, the Chief Executive Forum Fall Symposium. And feel free to check our website for registration and for further details. We also have a great lineup for regional link-ups coming up for BC, Alberta, Saskatchewan, and Atlantic. Please register for these link-ups, a great place for networking between all our members. We also have our Atlantic in-person conference. It is currently sold out for October 4th. And we have our virtual conference, Driving the Future of Digital Health Canada. That is open for registration. You will find that on our website as well. All right, so that is all the questions. I don't see anything else. Thank you so much for a great presentation, Dr. Glen. It was really a great presentation, very informative for everyone. If anyone has any additional questions, feel free to send an email to our webinars at Digital Health Canada email address, and I will make sure that Dr. Glen receives any further questions or comments you have for him. Okay, and my pleasure. And we also have a quick, less than 1 minute survey. If anyone could just click on that survey and just give us your feedback, would be greatly appreciated. All right, so if you have any final words for our attendees, Dr. Glen.
I just say I highly recommend whenever you're implementing technology, think about the impact on the workflow of your frontline staff, because often you're asking to do things, you need to find ways to soften the blow of transitions. And that was why this long strategy I shared today was all focused on making sure that in addition to offering value, frontline staff got something out of it and their day got better as a result of it. I would suggest it's worth investing in making your staff's day better, especially today.
Sounds awesome. Well, thank you all for being here today, and we'll see you all again next time. All right, have a great afternoon, everyone. Thank you.